Anesthesia is defined as a state of temporary induced loss of sensation as well as awareness. It consists upon a triad. The first point of the triad is analgesia, which is pain relief, paralysis, which is muscle relaxation, amnesia is memory loss. Now, who wants to remember their painful procedure? And before giving any anesthetic to a patient, we need to have a proper anesthetic protocols. The first part of anesthetic protocol is pre-medication. Now, pre-medication was all of those drugs that are given to the patient in order to prevent any grievous outcome that may occur in the procedure. It is also used to prevent all those comorbid complications such as hypertension. Now, if a patient has increased blood pressure, there is an increased tendency to bleed out on table during the procedure. So, such condition can be prevented by giving the patient antihypertensives. Now, our next point is induction of anesthesia. Now, induction is the word, it defines itself. Induction is to induce. Now, there are various drugs who induce as well as maintain the anesthetic effect, which we'll study in the subsequent slides. Our next point is skeletal muscle relaxation. Now, no one can dissect through a rigid body, so skeletal muscle relaxants are needed to overcome such a problem. Analgesia is for pain relief, and other drugs such as antiemetics are used because a lot of anesthetics have nausea and vomiting like symptoms to it. So this basically helps such effects. Now, the residual effect of any anesthetic is relieved by opioids and benzodiazepines, which are also sedative. Now, our last point is whenever we are recovering a patient, we need to reverse that muscle relaxant effect. So we use neuromuscular block. Now we move forward to anesthetic agents. Now, in broad categorization, it is divided into two parts: inhalational and intravenous. Inhalational are those drugs that you breathe in order to have a sedative like effect, but this is combined with intravenous drug to have its full effect. Inhalational is further divided into two types. One is the volatile liquids and the other is gas. Now, volatile liquid includes ether, halothane, enflurane, isoflurane, desflurane, and our most favorite one is sevoflurane. It is given to children and adults who have needle phobia. Gases include only nitric oxide. It helps to preserve the blood pressure as well as preserve respiratory reflex, an excellent analgesic. But the side effect of this drug is it causes delirium, and post-op side effects also include nausea, vomiting, greenhouse effect as it is dangerous for the environment, and it is mutagenic. Now we go towards the intravenous, but before studying that we need to know that there are two types of intravenous drugs. The one that induce the sedation and others that are used to maintain that sedation. So some have a single function and some drugs have a dual function. Example of the inducing drug is propofol. It sedates a patient within 8 seconds and it is given in continuous infusion for smooth muscle induction. And this drug is quality is that it is hemodynamically stable. Our next drug is thiopentone. It is also used in induction as well as maintenance. Now, this helps to reduce the metabolic rate as well as intracranial pressure. Hence, it is used in brain surgery and also in hypertensive because it helps in decreasing the blood pressure. Now, our next drug is etomidate, which is steroid derivative. It has a brief duration of action and it is hemodynamically stable. But the dangerous effect of this drug is it decreases the adrenocortical area, by which it can also cause Addisonian crisis. Now, lastly, our slow-acting drugs include benzodiazepam, which is diazepam, dissociative anesthetics such as ketamine, opioids including fentanyl, remifentanil, and even alpha-adrenergic are used as sedatives and has an analgesic effect such as codeine, which is also used in cough medicine. Now we move towards various types of anesthesia. Now, broadly, it is categorized into two types: general anesthesia, which has a full body effect, and local anesthesia, which has a regional effect. This includes the IV block, which is known as Beer's block, topical anesthesia, plexus block, spinal block, epidural anesthesia. Now, we'll study each of them individually. Now we'll move to its first type, general anesthesia, but before studying that we need to know its pharmacology.
First is general anesthesia, which makes the whole body lose feeling, movement, and consciousness. Drugs that are used to induce this type of anesthesia are called general anesthetics. Anesthesia performed with general anesthetics occurs in 4 stages that were first introduced and described back in 1930s. These 4 stages remain essentially the same over time. However, updated delivery methods and modern anesthetics have improved the speed of onset, safety, and recovery. So the first stage is known as induction. It is simply a period during which the patient goes from state of consciousness to a state of unconsciousness. Next, we have the second stage known as excitement. At this stage, depression of inhibitory neurons in the CNS leads to increased excitement, involuntary muscle movement, increased heart rate, blood pressure, and respiration. Next, we progress to the third stage known as surgical anesthesia. At this stage, there is a gradual loss of muscle tone and reflexes. Patient is fully unconscious, unresponsive to surgery, and has regular breathing. This is the ideal stage for surgery, and careful monitoring is necessary to prevent further progression to stage 4, known as medullary paralysis or overdose. At this stage, respiratory and cardiovascular failure occurs, which lead to death if the patient cannot be revived quickly. Now, let's move on to discussing how general anesthetics work. So the mechanism of action of general anesthetics is not entirely clear. Although early theories focus on a single common path of action for all anesthetics, at scopic level, the action of general anesthetics on thalamus and reticular activating system leads to reversible loss of consciousness. The action on the hippocampus, amygdala, and prefrontal cortex causes amnesia. And finally, the action on the spinal cord is responsible for immobility and analgesia. Now, at the molecular level, things get a little bit more complicated. So to make it simple, we can divide general anesthetics into 3 groups based on their relative abilities to produce unconsciousness, immobility, and analgesia. But before anesthetics, the first group consists of intravenous agents, etomidate, propofol, and barbiturates. These drugs are much more potent at producing unconsciousness rather than immobility or analgesia, and they are commonly used in the induction phase. Their effects appear to be mediated by a subset of gamma-aminobutyric acid type A receptors, GABA-A for short. So GABA-A receptors are located both postsynaptically and extrasynaptically on the majority of neurons in the central nervous system. They are composed of pentameric arrangements of subunits around a central ion channel pore. When endogenous GABA binds to this receptor, it causes a conformational change which opens central pore, allowing chloride ions to pass down electrochemical gradient. This in turn leads to stabilization or hyperpolarization of the resting potential, making it more difficult for excitatory neurotransmitters to depolarize the neuron and generate an action potential. So when etomidate, propofol, and barbiturates bind to specific sites on the GABA-A receptor, they prolong opening of the channel, suppress neuronal excitability, and thus promote unconsciousness. Now, when it comes to side effects, etomidate can cause adrenal suppression and transient skeletal muscle movements, including myoclonus. Propofol is known to cause respiratory depression and hypotension. Lastly, barbiturates can cause apnea, cough, bronchospasms. To the second group of general anesthetics, which consists of intravenous agent ketamine and inhalation agents nitrous oxide, xenon, and cyclopropane. In contrast to Group 1 and Group 3 agents, these drugs produce significant analgesia. However, their ability to produce unconsciousness and immobility is relatively weak. Because of that, these drugs are typically used in the maintenance phase of anesthesia. Unlike the drugs in Group 1, the Group 2 drugs have little to no effect on GABA-A receptors, and instead their effects appear to be mediated primarily by N-methyl D-aspartate receptors, NMDA for short. NMDA receptors are located in the spinal cord and are crucial in pain modulation and processing. When neurotransmitter glutamate binds to NMDA receptor, it causes inflow of extracellular calcium into the postsynaptic neuron, which then activates a series of signaling molecules, causing the pain signal to increase and fire more frequently. Now, ketamine, nitrous oxide, xenon, and cyclopropane selectively inhibit NMDA receptors, which ultimately prevents or decreases neurotransmission of pain. Group 2 general anesthetics also affect members of the 2-pore domain potassium channel family, which regulate the resting membrane potential of neurons. Specifically, they promote the opening of these channels, leading to increased potassium efflux, producing a reduction in neuronal excitability that contributes to their sedative effects. Now when it comes to adverse effects, ketamine can cause hypertension, tachycardia, and hypersalivation, as well as emergence phenomena, ranging from vivid dreams to hallucinations and delirium that may continue for 24 hours after treatment. Next, nitrous oxide and cyclopropane are known to cause dizziness, nausea, and vomiting. Lastly, we have xenon, which has many characteristics of the ideal anesthetic and has virtually no significant side effects. Now let's move on to the third group of general anesthetics, which consists of halogenated volatile anesthetics: halothane, enflurane, isoflurane, sevoflurane, and desflurane. In contrast to group 1 and 2 drugs, group 3 drugs have more diverse mechanism of action and are more potent at producing immobility. Studies suggest that volatile anesthetics produce unconsciousness via different GABA-A receptor subunits than those targeted by the group 1 drugs. Also, many 2-pore domain potassium channels that are activated by group 3 anesthetics appear to highly affect immobility rather than anesthesia. Just like group 2 drugs, volatile anesthetics also inhibit NMDA receptors. A wide variety of other ion channels are also sensitive to volatile anesthetics, including neuronal nicotinic acetylcholine receptors, serotonin type 3 receptors, sodium channels, mitochondrial ATP-sensitive potassium channels, and hyperpolarization-activated cyclic nucleotide-gated channels. Now, when it comes to side effects, all of the agents in this group produce a dose-dependent reduction in blood pressure and cardiac output. Additionally, halothane in particular may cause cardiac arrhythmias and hepatotoxicity, while sevoflurane may cause renal toxicity. Now, before we move on, there is one more agent that's worth mentioning here, which doesn't belong to any of the 3 groups that we discussed so far, and that is dexmedetomidine. Unlike the other commonly used general anesthetics, dexmedetomidine has a unique ability to produce sedation and analgesia without the risk of respiratory depression. These effects result from its binding to the presynaptic alpha-2 adrenergic receptors of the subtype 2A, which are located in the brain and spinal cord. The action on these receptors inhibits the release of norepinephrine, terminating the propagation of pain signals and inducing light sedation. When it comes to side effects of dexmedetomidine, the most common ones are bradycardia and hypotension, as well as transient hypertension due to weak peripheral alpha-1 receptor agonist activity. Now,
in general anesthesia, medications are given to patients to render them unconscious, and due to which they are unable to feel any pain during any surgical procedure. Now we'll go towards a demonstration. Now, what normally happens in the OT?
Let me show you the usual tools of engagement. Number 7.5 endotracheal tube, number 3 MAC blade, 90 millimeter OPA, some propofol, Zemuron. Over here, our IV starts up, but I already started the IV. Sorry guys, can't show you that today. The patient's ready to go to sleep. Here's the propofol lidocaine mixture. Let me give her enough to just drift her off. Here we go. You ready?
Yes.
All right. Take some nice big deep breaths for me. So she is asleep and the neuromuscular blocker's going in. I'm putting in the 90 millimeter OPA. And let's bag her, see how she does here. Nice. So everybody asks about bagging and ventilating. Here's my secret. You got to get that C-form and rotate the neck. Look how this lines up nice and straight. And it's just really, really nice and easy. You get that? So we're ready to intubate. So out comes the airway. Sublux the corner of the jaw nicely. Drop the blade gently down the right gutter and pull towards the feet. You guys can see that airway. It's beautiful. That's where I gotta go. Okay, so I pulled the tube back to 22 cms at the lip and inflated the balloon. We're good. That's what I like. can show you guys.
The basic purpose of general anesthesia is shown to you by the 5 corners of a star. It provides analgesia, amnesia, loss of consciousness, weakening of the autonomic response, and one of its side effects is motion sickness. Now we'll again discuss the administration of general anesthesia stepwise. The first phase being induction. Induction is either by inhalational agents such as halothane or by IV agents such as thiopentone, ketamine, and propofol. Intubation is by dexamethasone, which is a muscle relaxant. We give it approximately 1.5 mg per kg per body weight in the laryngoscope. Maintenance is by induced sleep. We give halothane. To cause analgesic effect, we give the patient nitric oxide, and for muscle relaxation, we give atracurium. For monitoring, we need to monitor the blood pressure, the temperature, and the vascular by assessing the ECG and BP.
Tracheal tube where she's. Now positioning is very important. So the arms are no greater than 90 degrees on these arm boards, as you can see, and that. So we're just a few minutes after induction. Heart rate's still a little high, but that's going to drop down as soon as I give her a little narcotic. Blood pressure is great. Gas flow is good.
Adequacy of ventilation is seen by pulse oximetry. Last step is recovery. First of all of the agents during given this procedure are stopped. Only oxygen is given. Muscle relaxation is terminated by neostigmine, and atropine is given to inhibit secretion as well as prevent gagging from their own saliva. And after that, intubatory tube is taken out. Now, how to ensure a better outcome of anesthesia is simply by monitoring and having trained anesthetic. Accurate monitoring of vitals like temperature, heart rate, blood pressure, ECG, and oxygen concentration and respiration is monitored by pulse oximetry. And the facility should have an accurate team for which CPR should be done upon patient if the code blue is initiated. Now, anesthesia is a very risky process, so it itself have a lot of complication which can be either intubation related, respiratory related, and even drug related. The intubation related problems are failed intubation, accidental bronchial intubation, trauma to the lips, teeth, pharynx, aspiration of the gastric content which result in gastric aspiration pneumonia, blockage or kinking of the tube, and delayed tracheal stenosis. Now, delayed tracheal stenosis is by damaging of the trachea, due to which later, whenever healing occurs, there will be tracheal stenosis, which means narrowing of the tracheal lumen. Now, this respiratory problem includes atelectasis, pulmonary aspiration, laryngoscopy, post-pneumonia, post-op pneumonia, pneumothorax, and laryngeal spasm. Now, drugs-induced problems are halothane can cause decreased cardiac output, as well as it can cause liver toxicity, whereas dexamethasone can cause hyperkalemia, pyrexia, and even allergy, whereas isoflurane causes respiratory problems. The general complications that can occur from general anesthesia includes hypothermia, hypoxia, hypoventilation. Now, there are 3H, 1P, and MDF. So this can be used as a mnemonic. H3PMDF. P is for pulmonary embolism, myocardial infarction, diaphoresis, and fire and electrical hazards. Now, one of the serious complications of general anesthesia is the failure to breathe after general anesthesia has been. Now, this can be caused due to obstruction of the airway, central sedation, hypoxia, hypercarbia due to overventilation, persistent neuromuscular blockage, pneumothorax, and central failure leading to respiratory arrest. Now, we studied a lot of disadvantages. Now, we'll go towards the advantages. Now, the advantages are long-time anesthesia. It is also an anxiolytic, decreased bronchial secretions, laparotomy is best done by this procedure, and children who have needle phobia. Local anesthesia. Now, local anesthesia is basically the induction of temporary induced loss of sensation. It consists of 2 points: analgesia, which is pain relief, and paralysis, which is muscle relaxation. Now, this type of anesthetic is given when general anesthesia is proven to be dangerous. That is in cardiovascular problems. If the patient is having myocardial infarction, you cannot give general anesthesia because it will be difficult for the heart to pump, because at that state a lot of muscles are in the state of relaxation, and in obstetric cases such as C-sections. It is also given in post-operative periods in order to reduce the risk of analgesics. Now, topical anesthetics are broadly categorized into two. One is eutectic mixture of local anesthetics, shortly known as AMLA, which is a mixture of lignocaine and prilocaine. And the other is Mofat solution or cocaine, which is given in nasal surgery because it has a specific effect of causing vasoconstriction. By vasoconstriction, the arteries would similarly, because the nose is supplied with a lot of blood vessels, so it has a greater tendency to bleed out. So by giving the solution, there will be decrease in the spillage of blood upon any cautery introduced. Now there are various types of local anesthesias such as IV blocks, topical anesthesia, plexus blocks, spinal anesthesia, and epidural anesthesia. But the first and then local anesthesia will study will be spinal anesthesia. Spinal anesthesia is given to people in procedures that are done below the umbilicus level, such as C-section, prostatectomy, and even pelvic surgery. Now, the procedure of this anesthesia is that first of all 1 liter of crystalloids are given to prevent hypertension, and the patient is asked to lie in a lateral position. The back is painted with iodine or pyridine. Now the anesthesia is given below L5, L4 and L5 level because there is the spinal cord termination point, which is also known as conus medullaris. Now, after that point has been identified, we draw an imaginary line from iliac crest by putting our hands upon both of the iliac crest, and we join the thumb to a center point. When the thumb joins to a center point, it imaginarily identifies L4 and L5 level. Now we generally rub our thumb up and down into the intraspinous space. Now this is an ideal space through which a spinal anesthesia is given. We will first make our concepts better by a video. Now as you can see, the back is painted with pyridine twice. Now we clean the skin with a spirit twice. This is for an antibacterial effect, so before giving any type of anesthesia and introducing something into the body, we have to adequately clean the outer area because it is normal flora to a lot of bacteria. Now we clean the skin with a dry gauze piece. Then we feel the posterior superior iliac spine and palpate at L3, L4 and L5 space actually, where the conus medullaris terminates or the spinal cord terminates. Now this is the person is feeling the intraspinous space. We mark it. Now we advance a 25 gauge spinal needle in the middle of L4 and L5. We penetrate through the skin, subcutaneous tissue, supraspinatus, intraspinatus, ligamentum flavum, epidural space, and then we enter the dura. Now we remove the stellate and look for CSF. It should be clear, fluid, freely flowing through it. After we see the fluid coming out of the stellate, now we connect it with 5 cc syringe, which is loaded with 0.5% bupivacaine, and in C-section we give it approximately 2.5 ml. Now we aspirate the needle to look for free flow of the CSF, and we inject the anesthetic drug. You aspirate once again, inject it, and it lasts before injecting 1 ml of the drug. Now take the spinal needle and syringe out together and put a gauze piece and apply a small sterile tape at the site of injection. So again, a brief review of this procedure. So we injected a spinal needle through the skin. Now you need to remember how many layers it has penetrated to enter that spinal space area. So we cross the skin, the subcutaneous fat, the supraspinous ligament, the interspinous ligament, ligamentum flavum, epidural space. Now remember, this space is used for epidural anesthesia. By crossing this space, we entered the area in which spinal anesthesia is being induced. Now we'll discuss its various advantages as well as disadvantages. The advantages consist of that no equipment is needed, no gas is given which may cause air pollution, no loss of consciousness, simple and cheap, and it causes abdominal relaxation. The disadvantages include headache. Headache is caused because when spinal tap creates a passage for the spinal fluid to leak out and changing the fluid pressure around the brain and spinal cord, resulting in headache. Hypotension is due to blockage of the cardiac sympathetic nerve, whereas spinal cord injury can also be resulted because of the wrongly positioned needle, as well as the respiratory system can be suppressed if anesthesia is given at an upper level of L4. Now, this symptom is one of the commonest symptoms due to which many people are fearful, hence they prefer general anesthesia over spinal anesthesia, which is back pain. Back pain is caused due to multiple factors. The pathogenesis of postoperative back pain include type and duration of surgery, duration of immobilization, as well as position of the patient during the spinal puncture. The diagnosis of back pain is not simple because contributing factor may include needle trauma, surgical positioning, injections of saline or local anesthetics into the intravenous spinous ligament, and development of supraspinous hematoma, excessive stretching of ligament after relaxation of the paraspinal muscles, and localized trauma to the intervertebral disc. Its relation with various types and size of the spinal needle is yet to be confirmed. Now, there are two types of complications by spinal anesthesia. One are the immediate and the other are late. The immediate complications include nausea, vomiting, spinal cord injury, needle breakage, paralysis of the respiratory muscles, nerve root injury, paresthesias, and hypotension. Whereas late complication includes neurological impairment, postspinal headache, meningitis, back pain, infections, disc prolapse, urinary retention, damage to the extradural vessels. Lastly, we'll discuss the contraindications. Some are absolute, whereas others are relative. The absolute contraindication for spinal anesthesia is as increased intracranial pressure because it will cause increased probability of CSF leakage. It should absolutely never be given to patient without consent. Blood diathesis, which is coagulation problems that can result in bleeding out to the puncture point, burning at the injection site, which is allergy at that some point, and systemic sepsis, whereas it can be a route or point of entry to many infections. Heart valve diseases, as relative contraindications include CNS disease on antiplatelets such as low plat, chronic back pain, and hypovolemia.